Got the Okay. I don't know how to do this. Okay. Good evening, everyone. Welcome back to another session of webinar. And of course, we are familiar with Prof. Dr. Hatim, who has actually given us some webinars before. Maybe this is the second or third one. And it is always very interesting to see him and also his cases that he's going to present. So Prof is very active in research. And without further ado, maybe we can get Prof to start.
Yeah, okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good evening. Thank you, Dr. Thank you very much, Dr. Betty, for the introduction, and thank you for having me here in your DocT program. It's a great pleasure to be presenting again.
Beating hearts.
Sorry,
Not
too hard.
cooperating.
Okay, too hard. Sorry.
Oh, yes. Also, beating hearts. Also, Dokiti. Dokiti is also involved. We are collaborating.
Okay.
Yeah. Okay.
All right. So I'll share my slide first. Yeah. Can you see my slide?
Not yet. Okay, we can see your slide now.
Okay, yes. Move it to slideshow. All right. Okay, so Dr. Betty have asked me to talk about interesting psychosis cases studies. So there's so many psychotic cases I've seen throughout my career. So, but for this session, I'll be focusing on two cases, highlighting two important disease that probably need clinician or healthcare professionals need to probably know. So I focus on schizophrenia and drug-induced psychosis or substance use psychosis. Yeah. So can you see my slide moving?
Yes, can.
Okay. So before we talk about psychosis per se, so I just want to highlight some misconception about mental illness, especially among the public. Yeah? So, because this misconception can lead to a delay in treatment, delay in seeking help, and also leads to poorer prognosis. Yeah? So, we as a healthcare professional should try to correct this misconception about mental illness. So first one is that a lot of Malaysian, especially the Malays, they believe in the mental illness is associated with charm, sucker, demons, bad spirits. I think which leads to some of these, especially patients with psychosis, ends up in the alternative treatment. They goes to the bomoh first, they goes to the traditional healers, they goes to the ustads. So this again delays the seeking health seeking behavior. So the longer you wait, the more difficult to treat. So psychosis, even though it's serious mental illness, serious medical condition, if you detect early, treat early, there's effective treatment, and patient actually can get back to normal function. Yeah? Another common misconception is that mental illness, or especially psychosis, only occurred among those who are weak, lazy, not talented, low socioeconomic class, which is, I think, again, very wrong misconception or very stigmatizing. There's a lot of actually famous, world famous people who suffers from psychosis. You look at when you just Google, example, Professor John Nash, he's a mathematician who won a Nobel Prize in 1994. He was diagnosed to have schizophrenia in 1960. However, with proper treatment, he actually come out and able to come up with a lot of theory, mathematics theory. And in 1994, he won a Nobel Prize. So not even one Malaysian have won a Nobel Prize. A patient who suffers from schizophrenia won a Nobel Prize in mathematics. All of us know Vincent van Gogh, very famous Dutch painter. So he suffers from psychosis. Some people say schizophrenia, some say he probably have bipolar. But he's definitely talented painter. Some of his paintings worth 100 million US dollar, recently, an artist, Selena Gomez, you can even Google this, and she suffers from psychosis in 2018. And she's world famous artist, actor, singer, songwriter, and so on. So it's not just those who are weak-willed, lazy people. So this is definitely a misconception and stigmatizing. And most importantly, psychosis or mental illness, you need to seek treatment. You won't recover by itself without treatment. So it is a medical condition. You need to get help. Early and proper treatment will lead to improvement and even returning back to normal function. Okay. So mental disorders are actually brain disorders, medical condition, just like heart disease. Dr. Betty is a cardiologist, so she sees a lot of heart disease. So we psychiatrists see a lot of mental disorders, which are brain disorders. So it's not the disorders of lesion like stroke or Alzheimer's disease. So you do CT scan, MRI, you can't see any lesion. But this is more disorders of the brain circuitry. So mental disorders results from complex genetic factors. So there's no one single factor. So it's interplay of genetic factors, developmental factors, and environmental factors. And the good news is that current treatments can help patients get better and recover from the illness and even from psychosis. So let's start with the first case. So I have a patient of 27 years old, a male, who works as a technician, already married, brought to the psychiatric clinic by the wife. So the chief complaint is threatening behavior. He's threatened his office mate. So this patient has been working at a construction company for more than 4 years. However, past 1 year prior to seeing me, noted to have deterioration in his performance, work performance. So 6 months prior, started to have persecutory delusions, where he believed that his office mate is trying to harm him or even make him lose his job. And on and off, he's also been hearing voices, the voice of his office mate and neighbors talking back about him and even ridiculing him. So because of the symptoms, he had poor sleep at night, started to be socially withdrawn and does not want to mix with even his family members and relatives. He does not abuse drugs or alcohol, and there's no previous medical or psychiatric illness prior to seeing us. So there's significantly reduced amount of speech, and it's very preoccupied with his own thoughts when I see him in the clinic. And recently, he starts to show threatening behavior towards his colleague at work. So thus, the employer asked the wife to bring patients to hospital for assessment and treatment. So actually, this patient suffers from schizophrenia. So what is schizophrenia? So schizophrenia is a serious mental illness. It's a chronic, can be severe and disabling disease, especially if you don't treat or don't detect early. Fortunately, it only affects less than 1% of the population, but because it's a chronic illness, it's accumulate and it starts early in life, the teenage or early 20s. So because of this, the numbers accumulated. So it's found all over the world, and it counts for about 50% of psychiatric admissions. So you go to the mental hospital or psychiatric ward, probably almost half of the patients in the ward are actually suffering from schizophrenia. So this is a serious illness that impairs multifunctions of the person. So it disturbs the perceptions. That means they start hearing voices. They start seeing things that others can't see. So they impairs the patient's perception. It disrupt the patient's thinking. So they have abnormal thought content. They start having abnormal belief, what we call delusions. So they think that people are spying on him. People have uh, ill intention and all various types of delusion. So of course, you hear voices talking bad about you, people trying to harm you, you start to become worried, you can become depressed, it affects their emotions. And at the same time, sometimes they can become aggressive, reacting to all these psychotic symptoms. So it's definitely affecting their social interaction. When you have psychosis, you will become paranoid, you don't want to mix around, you think that everything is dangerous. And this in turn affect the patient's functioning. So it occurs early in life, so affecting young people, especially the adolescent or early 20s. So if you are above 45, older people like me, chance of getting schizophrenia is very, very rare. So it normally occurs in young age person. The risk among male and female is equal. In certain diseases like depression, higher risk in female, but for schizophrenia, risk is equal between male and female. So what are the etiology causes? So it's can be divided to biological factors. So there's a lot of theory. One of the most important theories is what we call dopamine hypothesis, where there's abnormal dopaminergic activities in the brain. So actually this hypothesis, those who proposed this hypothesis, again, the scientists that proposed this hypothesis won a Nobel Prize in 2001, Professor Arvid Carlson, who come up with this dopamine hypothesis, one of the bases of schizophrenia. So there's hyperdopaminergic state at the limbic system, and also there's hypodopaminergic state at the frontal lobe. There's also other neurotransmitters are involved, like glutamate, serotonin, and so on. Yeah. So there's also brain abnormalities. So there's especially chronic patients. Schizophrenia is associated with brain cell loss. So after a while, you can see that there's ventricle enlargement and hypofrontality occurring. Of course, there's also a lot of genetic factors involved. If you have family members who have schizophrenia, your risk of getting schizophrenia is much higher. So this is based on family studies and twin studies. For example, you have a monozygotic twin who have schizophrenia, identical twin have schizophrenia. If you have identical twin and he or she has schizophrenia, then your chance of getting schizophrenia is about 50%. So if one of your parents have schizophrenia, your chance of getting schizophrenia is probably around 10%. So that's the genetic aspect of schizophrenia. So just touching a bit on the dopamine hypothesis of schizophrenia. So there's at least 4 different main dopaminergic tracks in the brain. There's a mesocortical pathway, which controls the cognition and motivation. There's a mesolimbic pathway, which controls memory, emotion, and pleasure. And there's also nigrostriatal pathway that controls motor movement, and the tuberoinfundibular pathway that basically regulates the prolactin secretion. So according to the dopamine hypothesis, there's hyperdopaminergic state at the limbic system. So this gives rise to symptoms of delusions, abnormal thought, they have abnormal belief. It gives rise to hallucinations, the abnormal perception, they're seeing things that are not there. They can hear things that are not there. They can smell things that without any stimulants and so on. Yeah? And this also leads to disorganized thought, speech, and behavior. There's also hypodopaminergic state occurring at the mesocortical pathway, leading to negative symptoms, which are alogia, affective flattening, and ovulation. I will talk more about negative symptoms in the subsequent slides. So what are the other etiological factors? Includes environment and psychosocial factors. So if you have predisposition of the genetic and abnormal dopamine tracks, and if you are exposed to certain stressful lifestyle or stressful life events, this can initiate the occurring of the illness. Yeah? So adverse living conditions like lower social class, high emotional expression, any death in the family, financial problem, relationship problem, this can all triggers the onset of the schizophrenia. So what are the clinical features? Can be divided into positive and negative symptoms. So positive symptoms appear to reflect an excess or distortion of normal functions. For example, the hallucinations, the delusions, the disorganized speech, disorganized behavior. Whereas negative symptoms reflect a diminution or loss of normal functions. So positive symptoms, quite straightforward: hallucinations, delusions, disorganized speech, disorganized behavior, including aggressive behavior, and so on. Whereas negative symptoms examples include affective flattening, where you can see that their patients become less responsive, their face become immobile, poor eye contact, that's reduced in body language. There's avolition, The patient presented with apathy, lack of energy, that's not interested in performing their daily activity routines like grooming, bathing, keeping their personal hygiene. Alogia, there's a reduction or absence of speech or poverty of speech and content of speech. And anhedonia, the inability to express or even experience pleasure. So these are the negative symptoms. So there are other symptoms, of course. The positive symptoms and negative symptoms are the main symptoms. They affect the patient's cognitive function. They have poor attention, poor memory, poor executive functions, and also they become depressed. Of course, you have hearing voices. You have of all these different kind of delusions and hallucination. You tend to be depressed. This can also lead to aggression and hostility or even suicide. There's also a high risk of uh, substance use disorder among patients with schizophrenia. They try to self-medicate and abuse substance as well. So unfortunately, this is a serious complication associated with schizophrenia. So the mortality rates are very high compared to the normal population. Patients with schizophrenia died on average 10 to 15 years earlier. So their life expectancy is shorter than average population. So this is because of suicide, mainly suicide, but also due to other medical illness, especially cardiovascular disease. So there's higher risk of developing diabetes, obesity, and cardiovascular disease among patients with schizophrenia. Probably they don't take care of their health properly. They don't exercise. Probably they don't take care of diet. They isolate themselves. And so these are some of the condition can lead to early death. So it causes a lot of impact, not only to the patient, but also to the families and society. So to the patient, it's cause significant social functioning and occupational dysfunction. So they tend to become unemployed, dependent on the families. So this also gives a lot of burden to the families, especially fear, embarrassment, social stigma, and so on, and to the society. So since they are affecting the young ones, they are not contributing to this economy. So there's loss of function, and also because of the treatment cost, hospitalization, suicide, all this can cause significant burden to the economy and cost millions of ringgit to our country, especially if you don't treat early and don't detect early. So what about treatment? So it can be divided into biopsychosocial, but the mainstay of treatment is still the biological treatment, or what we call medications. So antipsychotic are the most important treatment strategies. And of course, we also need the psychosocial treatment, but we need to use medication, the biological treatment. And fortunately, we have a lot of medication nowadays, even the newer medication, which are very effective, safe, and with the least number of side effects. So antipsychotics are available in 1950s. So the first antipsychotics that been discovered is chlorpromazine and haloperidol. So I think all of us knows these two and still widely used, but they have a lot of side effects. So they are considered as first generation antipsychotic. In 1990s, we have the second generation antipsychotic with more effective, lesser side effects. Example, risperidone, olanzapine, quetiapine, ziprasidone, and so on. And now we have even newer, third generation antipsychotic. We call it dopamine partial agonist. Example, aripiprazole, cariprazine, brexpiprazole. So in terms of medication, we have oral formulation, we have injectable formulation, we have even depot formulation. So patient with psychosis, they normally have poor insight. They don't realize they have this psychotic symptom. They don't realize that they are ill and need treatment. So because of that, they tend not to take the medication. So in this type of patient, then probably we need to give depot injection, where we give 1 monthly injection, or even we have 3 monthly injection. So you just give one shot every 3 months. For example, the paliperidone 3 monthly depot injection. So these are the mechanism of action of the treatment antipsychotic. The first generation antipsychotic, we call it dopamine antagonist. For example, haloperidol, promazine. They are still very effective, but there's a lot of side effects associated with first generation antipsychotic. The advantage, they are very cheap, can be found almost in all the hospital, but there's a lot of side effects, basically. The second generation antipsychotics, we call it serotonin dopamine antagonists. Example, olanzapine, risperidone, quetiapine. Relatively cheaper than the third generation, widely available in all the hospital in Malaysia. Much better than first generation, but they still have their own side effects, especially in terms of metabolic syndrome. They can cause a lot of weight gain, cause increase in lipid, increase in higher risk of getting diabetes, for example. So the newer one, we call it dopamine partial agonist. Example, aripiprazole, brexpiprazole, and cariprazine. They are slightly more expensive, but they are very effective as well for positive symptoms, negative symptoms, mood symptoms, and they have very good safety profile compared to the first and second generation. So it's also available in most of the hospital in Malaysia. So what are the treatment challenges? First is what I mentioned earlier, the compliance. So patient with schizophrenia, they normally have poor insight. So they don't take the medication consistently. So they stop taking the medication, especially the oral medication. So this poor adherence leads to high risk of relapse. So as high as 50% of the patient don't take medication regularly, and this leads to about 75% of patients relapsing because they don't take the medication. So relapse will increase risk of hospitalization, and this leads to increase in healthcare costs. What about the non-pharmacological treatment? So we have the psychosocial rehabilitation program, we have psychoeducation, we have cognitive therapy, social skill training, supported housing, and financial support. So there's a lot of psychosocial treatment available as well. So it's holistic biopsychosocial treatment. The key word here is that we need to detect early and give early intervention. With early detection, early intervention, patient can recover well and go back to the society and go back to function. So for the first half, summary of schizophrenia is severe mental illness. Early detection, early treatment is very important. Effective treatment are available, it's widely available in all the government hospital, even the private clinic. Compliance to treatment will improve quality of life and everyday functions of patients with schizophrenia, and we need to again early detection, early treatment. Okay, so next we go to the second case, which is drug-induced or substance-induced psychosis. It's getting much more now, especially in urban areas. Yeah, kind of see this almost every day in our A&E and in our clinic. So a 21-year-old male student, single, was brought to the emergency department by the parents and police. So noted changes in behavior for 2 weeks, presented with early irritability and paranoid behavior. So patient stopped interacting with the parents and isolate himself in his room for the past 2 weeks, stopped going to college and not sleeping at all. So started to talk to himself for past 1 week prior coming to the hospital. And one day prior to coming to the hospital, he was shouting at the parents and threatening them with a knife. And thus the parents have to call the police. And he told the police that the parents was planning to kill him. So he have no previous psychiatric or medical illness. And unfortunately, he has been abusing methamphetamine, shabu, for the past 2 months. It was introduced to him by his friends from college. So the friend said this shabu is good to relieve stress and increase energy and reduce sleep so that he can study more. So in the emergency room, he was given benzodiazepine and antipsychotic because he was very aggressive towards the staff. And he was admitted to psychiatric ward for further management. So this is a case of methamphetamine-induced psychosis, which is getting very common now. Okay, so what is stimulant? Methamphetamine, amphetamine, and all is under a group what we call stimulant or amphetamine type stimulant, or ATS we call it. So So ATS refers to a group of drugs, including amphetamine, methamphetamine, MDMA, or ecstasy. There's also other drugs like phenytoline, ephedrine, pseudoephedrine, methylphenidate. So these are all grouped under stimulants. Natural occurring stimulants like cocaine. So this amphetamine, methamphetamine, MDMA are all synthetic stimulants. There's natural occurring stimulants like cocaine, ketone, khat. These are natural occurring stimulants. So amphetamine type stimulants are used for medical reasons as well. For example, methylphenidate can be used for ADHD. If you suffer from narcolepsy, then the neurologist might give you stimulants, or you have chronic fatigue syndrome. You probably required stimulants as well. But unfortunately, most of these drugs are mainly used illegally for recreational purpose in the discos, nightclub, for enjoyment purpose. So leading to various consequences, including psychosis. So it comes, illicit stimulants comes in different forms and different names. So they can smoke it, can sniff it, can inhale it, even inject it. So methamphetamine found on the street comes in terms of powder, crystal, or even pills. So it's white, normally odorless, bitter tasting, easily dissolved in water or alcohol. So the most common one in Malaysia is called ice, or known as crystal, glass, or shabu. So this is the most purified form of methamphetamine. And it was being washed in solvent to remove the impurities. It's as high as 80% or even higher. And because of that, have very long-lasting physical effect, and it have a lot of complication if the person takes it. So it can be smoked in a glass pipe or piece of aluminum foil known as chasing the dragon. It can be swallowed. It can be used in multiple ways. So for those who have not seen it before, so this is how it looks like, the crystal methamphetamine. So this is what we call look like ice, crystallized form.
Sorry,
So
Prof. You
yeah,
mean if it's more pure, the effect is longer lasting?
more pure effect, longer lasting, but more complication.
More complication. The
And it's difficult,
complication, I see. Okay.
but more difficult to get away from it. A higher risk of dependence.
I see.
And okay, never mind. I explain why. All right. So other form of stimulants include ecstasy or MDMA. So it's a chemical derivatives of methamphetamine. So it also comes in form of powder, crystal, multiple colors. Uh, so the problem is that all these stimulants, methamphetamine, amphetamine, can be easily produced in all these clandestine lab. So ingredients are commercially available and relatively inexpensive. So it's not very difficult. You don't need to be a chemist to produce all this. And you don't need to have special advanced technical skill. That's why you have a lot of all these illegal labs, even in Malaysia. And the precursors are actually norepinephrine or pseudoephedrine. These are actually antihistamine that we use for our
Oh,
URTI,
I see.
pseudoephedrine. Yeah, so these are all the precursors for amphetamine and methamphetamine.
Oh, interesting. Okay.
Yeah, so actually you can Google how to produce it, but I don't advise you don't to do that because you might be hanged. The police might find you, and but actually it's very easy. Okay, so how does it affect? So all this methamphetamine, if you smoke it, goes to the brain very fast, just like nicotine goes to the brain within seconds. And the higher the purity, the longer lasting. A single dose of pure methamphetamine can last up to 8 hours. So you smoke it, enters your lung, it enters your heart, pump it to the brain within seconds. So once it enters the brain, what does it do? So methamphetamine enters the nerve cell and release dopamine. So remember just now, dopamine is also involved for schizophrenia. So dopamine have a lot of functions. So it involved in movement control, involved in motivation, involved in endocrine hyperproteinemia, and it's also very important in reward pathway. So when it enters the brain cell, it facilitates the release of dopamine. So when there's a lot of dopamine, especially in the limbic system, it creates a feeling of rush, feeling of pleasure. You feel a lot of energy. You feel extremely happy. Not just happy, extremely happy, elevated euphoria. That increase your power of thinking, power of reasoning. You become hypersexual. You don't need food. Yeah? You feel strong. You can fight anybody. So you don't
Wow.
need sleep. So this is what they want. The immediate effect of increase in dopamine. So I mentioned earlier, dopamine is important in your movement, control and movement, important for motivation. And it's also very important in reward and well-being, which leads to addiction. So all drug of addiction will definitely increase in dopamine level. So if you use methamphetamine, it's a synthetic stimulant. It create a rush in dopamine secretion in this is your reward pathway involving the ventral tegmental area, nucleus accumbens, and frontal cortex. So this is what we call the reward pathway in the brain. So if you take all these stimulants, it will lead to increase immediate rush in your dopamine level. So it's even higher. Cocaine is a natural occurring stimulant. Methamphetamine is the synthetic. So it's even higher than the natural occurring stimulants. But the problem is that this is temporary. Yeah? So the stimulants behave like our credit card. Say they only facilitate release of money. They don't produce money. Yeah. So if you abuse your credit card, you swipe your credit card, you shop, you spend. Of course, you get all these things you want to buy. You feel happy for one day, but you suffer for the next few months to pay your debt. So similarly, these stimulants, all the synthetic or natural occurring one, they facilitate the release of dopamine. They don't produce dopamine. So if you use up all your dopamine for the next 1 month or 2 months, you lead to the bankrupt of your dopamine. Just like if you use your credit card too much, you can become bankrupt. So this leads to what we call the crash. So they initially they feel happy, but during the crash, they start having withdrawal symptoms. They feel depressed, they feel agitated, they feel low energy, and to get rid of this feeling, they need to get more of this methamphetamine just to feel normal again. Just those who abuse credit card, so they cannot pay the debt to the bank, so they borrow from a long loan shark. So this makes things more difficult. So this is the vicious cycle. Just like you bankrupt using credit card, then you borrow money from Along or loan shark, and your life become miserable. So similarly, in the brain, we use stimulants to to uh, to make us feel happy for a few hours, but your life become miserable for the next months or years. Okay, so during withdrawal or during the crash, you become depressed, you have psychomotor agitation, you develop sleep disturbance, you become irritable, you have anxiety, intense drug craving, and hyperphagia. Okay, so there's a lot of negative consequence affecting not only the family, community, involving a lot of crime and economic consequence. So substance abuse, drug abuse have major negative impacts on the person, the family, and the country as a whole. So what are the long-term effects? Medical long-term effect. Yeah? So it can cause dopamine depletion due to chronic use. So it can lead to irreversible neurological changes. So this can lead to cognitive impairment, behavioral problem. So long-term use patient can show signs of memory loss, almost similar like Alzheimer's disease. also have a lot of negative health effect that difficult or impossible to reverse. Yeah? So it leads to a lot of physical appearance changes. So it's what we call pro-aging. So you want to look older than your age, then you abuse stimulants. Yeah? You tend to lose a lot of your facial muscle. It leads to a lot of severe malnutrition, severe dental decay,
Oh my God.
poor skin. You have a lot of all this allergic reaction. So you definitely can see the aging process occurring. So this is what we call pro-aging drugs. It also affects the cardiovascular system. It can cause ischemia, myocardial infarction, tachycardia, increased risk of stroke. Respiratory system cause pulmonary hypertension, infectious disease, yeah, especially use IV, STD, bloodborne infectious disease, HIV. And again, when patients are high on drugs, they have becomes hypersexual, then unprotected sex, and again leads to a lot of STD. Yeah. Okay, effect on the skin because of the acid and bases that they use to produce the crystal. They use a lot of ammonia. They use a lot of hydrochloric acid. So this leads to a lot of allergic reaction to the skin. So it becomes dry, becomes they have this allergic reaction, becomes very itchy. They scratch their skin, leads to a lot of skin abscess, ulcers. Again, because of the ammonia, the bases, and the acids, they have hepatotoxicity, which is very damaging to the liver. They don't eat well, so they tend to have these giant ulcers. And ischemic colitis impact on the teeth. They have all these rotten teeth, gingival enlargement, caries, enamel erosion, xerostomia, muscle trismus. You can see if young people have very bad teeth, suspect stimulant abuse because again from the acid that they use when they smoke it, there's the acid that when they process during the processing of the stimulant, they use a lot of acid. So when they smoke it, the acid will erode the teeth. And one of the most common complications is, of course, the psychosis. And amphetamine-induced psychosis is actually very, very common. So if you use stimulants, your risk of getting psychosis is very, very high. The higher stimulants you use, the higher risk of getting psychosis. The more pure stimulant you use, the more risk of getting psychosis. If you still remember the dopamine hypothesis, yeah. So if you have hyperdopaminergic state in the limbic system, leads to hallucinations, leads to delusion. So you use stimulants, you are inducing the hyperdopaminergic state in your limbic system. So limbic system is part of your reward system as well. So you use a lot of stimulants, induce a lot of hyperdopaminergic state. This leads to psychosis. Yeah. So if you have schizophrenia, for example, you have pre-existing psychotic illness, you use stimulants, then it's even worse. So the risk of psychotic or relapse is very, very, very high. So what are the symptoms of psychosis? Just like patients with schizophrenia, they have hallucinations, they have delusions, but worse still, they have irritability, physical aggression, hypervigilance. So they becomes aggressive. This can lead to a lot of violent, even murder case and so on. So this is actually very dangerous to have. So we did a lot of studies actually in patient with stimulant abuse. So in one of the study, we look at almost 300 subjects who abuse or dependent on stimulants, and almost half of them have history of psychosis. So that 50% chance of a person who abuse stimulants becomes psychotic. And even after stopping the stimulants, about 13% of them still having psychotic symptoms despite stopping. So this is again very, very dangerous substance to use. So in summary, I think this is my last slide, and probably after this we can have some discussion. Stimulant abuse and dependence is gaining popularity. Unfortunately, is a common problem in Malaysia, associated with multiple social, economic, and health complications. And psychiatric comorbidities, especially psychosis, is very common. Now they use it in form of vape. They get it online, and we don't know what is inside the vape. Sometimes it's synthetic stimulants. So some patients who are vaping, they start become psychotic. So this is very, very dangerous. And I support that they should ban vape altogether in Malaysia. I think in Malaysia only Johor, I think, have banned vape, and I hope other states will also ban vape as well, because it's the number of stimulant psychosis can increase because of this. I think with that, thank you for your attention, and I pass the floor back to Dr. Betty.
Okay, so are you trying to say that in vape, it is not the same content as in a cigarette?
Yeah, because we don't know what is inside. Nobody regulates it. It can be anything. It can be the synthetic stimulant, it can be nicotine, it can be ganja, it can be LSD, it can be anything. Because who regulates it?
I see.
So it's very dangerous, actually.
Okay, are there any questions at all from the floor? Or from Dr. Wait, hold on. I'm perpetually busy with this the forms that they want the e-cert, which is very, very important to them. Are there any questions at all? So how do we, okay, going back to vape, because I really am very...
There's one question, I think, Dr. Reed.
Okay, can you...
Okay, I just look at my chat.
Okay, you could look at...
Good evening, Prof. How effective is using antipsychotic drop as a mode of treating schizophrenia? Is it still being used? Okay, so I mentioned a little about the antipsychotic. We have various formulation. We have oral formulation. We have injectables. And oral, we have tablet form. We also have liquid form. But not all antipsychotics are available in liquid form. So I think fluenzol have some liquid form, and risperidone have liquid form. So it's not widely available, but of course it's very effective as well. It's very useful, especially to treat those who have poor insight. Some of the relatives, they mix the medication in the patient's drink, because when they are psychotic, you don't think you are psychotic. So especially when you're paranoid. So some of these relatives, they mix the medication, the liquid form inside the drinks. So it is effective, but it's not widely available. So to get it can be a bit challenging. Yeah. Okay, there's another question. How do you treat Parkinson's side effects of antipsychotic? Yes. One of the old drugs, especially the first generation, the haloperidol, chlorpromazine, is associated with what we call extrapyramidal side effects. The dopamine will block the nigrostriatal pathway, leads to symptoms we call Parkinsonism, akathisia, bradykinesia. So one of the way to prevent it by using the second generation antipsychotic, for example, the olanzapine, quetiapine, or even the third generation antipsychotic like the aripiprazole, brexpiprazole, cariprazine. They have very, very minimal extrapyramidal side effects, or even the Parkinsonian side effects. But if you don't have the second generation or third generation, and you use haloperidol, and your patient develop Parkinson's symptom, then you can use anti-Parkinson like anticholinergic medication to treat the Parkinson's side effects of antipsychotic. But the best is to use the newer generation antipsychotic, the second generation or the third generation antipsychotic, because they don't have all these extrapyramidal side effects. Okay, I hope that answers your question. Okay, treatment of...
Are you done? Sorry?
Yeah.
Okay, Dr. Ng from Facebook asked, How fast can the acute psychotic episode be controlled with medication?
Very fast. You can see again depends on the severity. Because it's very severe, might take few days. It's not very severe, mild to moderate. Within hours, you can see the effect. So actually, antipsychotic works very fast. If you give the, let's say, agitated, disturbed patient, you give IM haloperidol, you can see they come down almost immediately. Yeah. So the effect is very fast. Actually, the positive symptoms is very fast.
Is paranoia a symptom that is difficult to treat? Is because
Paranoia is not difficult to treat. If you are paranoid, I give you antipsychotic, your paranoia will disappear. But the problem, it will disappear. But the problem is you don't continue taking the medication because you don't think you are paranoid. You think everybody in the world is talking bad about you. They have ill intention. So why do you want to take medication for that? Because the problem is not you, it's them. So they have what we call poor insight. If you are paranoid, you're psychotic, you take any of the antipsychotic, it will disappear. It definitely will disappear. Because positive symptoms are very easy to treat.
negative symptoms
Negative symptoms are more difficult to treat. Because positive symptoms is because of hyperdopaminergic. So you just block the dopamine, it disappears. But the negative symptoms is hypo. You don't have enough dopamine in the frontal lobe. So it's difficult to increase the dopamine in the frontal lobe. So you need more other receptors.
So both are dopamine, but one is hyper and
one is hypo, yeah.
But at different part of the brain.
Yes, at different part of the brain. So that's the pathology of the illness. That's why the patient develops that symptoms.
Maybe
so
we can give a little bit of your amphetamines.
Then they become more psychotic because the amphetamine is not selective. It goes throughout the brain. So that's why the antipsychotic, they are formulated to work differently at different brain areas.
That's a very difficult thing, that one is hypo and one is hyper and same chemical that is involved.
So that's why the third generation, we call it partial agonist. It's a dopamine stabilizer molecule. So at in brain areas, there's high dopaminergic activity. It works as a blockade. So in areas where there's low dopamine activity, it works as a stimulant. So this is what called partial agonist concept. So high activity, it blocks it. Low activity, it stimulates it. So it works both ways, either in the hyperdopaminergic or hypodopaminergic.
Okay, I think Dr. Yip asked, is atypical antipsychotic commonly used atypical as an application of depression? Is it effective?
Yes. Correct. This is correct. Atypical means the second generations like olanzapine, quetiapine, aripiprazole, brexpiprazole. According to the guideline, this is different topic for depression. So major depressive disorder, for those who do not respond to first line treatment of antidepressant, so the guideline says you can either switch to other antidepressants, or you can combine two antidepressants, or you can augment with antipsychotic, atypical antipsychotic. Because the new antipsychotic, they don't just block the dopamine, they also antagonize this serotonin 2A, for example. They antagonize serotonin 7, for example. So by antagonizing the serotonin 2A and serotonin 7, it increases dopamine or even norepinephrine in certain areas of the brain. Thus, it helps to improve the mood or in patient with depression. So yes, atypical antipsychotic can be used for augmentation of depression, and it's actually very effective. There's a lot of papers to support that. Then there's also Dr. Christine Saw asking about treatment of substance dependence is by addiction specialists in the hospital. Any role of the GPs? If you have the capacity, I mean, you have the ability to diagnose, you have the time to and energy to manage, of course, by all means, you can manage in GP setting. But again, depends on the severity and whether it's just recent onset, chronic, or and any further complication that the patient have. So complex cases, best to refer to hospital. Probably just started very good social support. You have the biopsychosocial means of helping the patient. Then, of course, by all means, you can treat substance dependence in the GP practice as well.
Can I ask why is it called an atypical antipsychotic? Why
Okay,
atypical?
that's an old terminology. So the first generation is called the typical
Oh,
psychotic. Then the second generation, they call it atypical antipsychotic. But scientific nomenclature, the first generation is called dopamine antagonist. The second generation is called serotonin dopamine antagonist. The third generation is called dopamine partial agonist. So this typical, atypical is the old term
okay.
because the first generation is called typical, the second generation is called atypical. Yeah.
Okay, I think Dr. Alice asked, why did patient who is taking antipsychotic, the unusual behavior symptoms seems to have no change? Sometimes we serve the medication at 8 p.m. and the patient, I think she may be a nurse, but patient is so active at night and then start to sleep in the morning time. Should we then change the timing of the medication?
Okay, so again depends on the diagnosis, depends on the what medication because the antipsychotic there's a lot of different types of medication. Even if we can group it first generation, second generation, third generation, but individually they behave differently. Some are more sedating, some are less sedating. For example, olanzapine, quetiapine, all these pin group, they are very sedative medication because it blocks the histamine. So this type of medication, probably if you serve, they will fall asleep. And again, it depends on the dosing as well. Higher dose, then probably cause a lot of somnolence. But the newer ones, like the cariprazine, aripiprazole, or lurasidone, there's less sedating. So even if you give at night, they probably do not sleep well because this newer medication do not block the histamine receptor. So it's not sedative enough. So probably you have to add on benzodiazepines or hypnotics to induce sleep. So it depends on which antipsychotic and again depends on the diagnosis as well. Certain diagnoses like bipolar, when they are manic, they don't need sleep. Yeah, they have decreased need of sleep. Then probably have more difficult or need higher dose of patient to make the patient sleep. Or even patient with dementia, for example, sometimes difficult to induce them to sleep. So again, depends on case to case basis and depends on the type of medication.
Okay, we'll take the last question from Christine and says that private psychiatrists using combination of antipsychotic and depression and anxiolytic in one patient. Why is it so?
Unfortunately, I cannot comment on the
Yeah,
private psychiatrist because this is based on individual
yeah,
and it's case to case basis, depends on the familiarity, expertise of the doctor, and also depends on the
clinical.
patients. So we cannot generalize, make a generalized statement.
Yeah.
But I'm sure there's a reason why they combine it, and yeah, so it's very difficult for me to comment on a general statement like this.
I think it's a very important topic, schizophrenia, because it is a very treatable disease when treated early. I've seen it myself when I did psychiatry. And I have to say today, I'm very proud. One of my best friend who was diagnosed to have a psychotic episode. I don't know whether she is a bipolar or whether she has schizophrenia. But today she and her company patented something that she invented.
Wow.
Yeah. So
Yeah.
she's actually an inventor, and she has, since the treatment, actually what we found her missing, and then she was at the road, like lost and crazy. So, and then, but she has very good insight. So, and the other thing is, I think the other take-home message is that to all the younger people, that recreational drugs are not so recreational after all, right?
Yeah, dangerous, very dangerous.
Yes, I think so,
Mm,
because it is very common, even among older age group like
Yes.
mine, when they go, gambling or
Mm,
partying, they take it,
yeah.
they take
Yeah.
ecstasy,
Mm,
very common. So with that, thank you very much. And I hope to bring you back again. Maybe we'll
yeah.
talk about depression.
Yeah,
Oh,
sure.
yes. And I think we can talk about depression and mood and other topic. Yeah.
Yeah. Yeah. All right.
Yeah,
So
it's very interesting and very good talk. Thank you so much,
thank
Prof.
you. Okay. Bye
Okay,
bye.
then. Bye.
Bye bye.
To everyone else, okay, we stop recording.